after our break. And we have legislative counsel with us who is going to walk us through the amendment and I don't know if it's in the underlying bill or.
I still have it as standalone.
Okay, still standalone.
Post language draft.
Yes.
2.3.
Yes. Good morning, Jen Carby from the Office of Legislative Counsel. I'm putting language up. So this is changes from yesterday. I left the effective date pieces just because I think they're important and I want to remember to put them in the actual bill. But I have incorporated all of the changes we looked at yesterday, and then everything new today is highlighted. So based on what we had yesterday, hospital shall not submit a claim to an insurer for reimbursement of a prescription drug administered in an outpatient or office setting in an amount that exceeds 120% of the average sales price as calculated by CMS for any drug for which the hospital charged any health insurer more than 120% ASP in effect as of April 1st, 2025 for any prescription drug administered in an outpatient or office setting for which a hospital charged a health insurer 120% or less of the ASP in effect as of April 1st, 2025, the hospital shall not charge the insurer a greater percentage of the ASP as calculated by CMS for that drug than the percentage of the ASP the hospital charged the insurer as of April 1st, 2025.
Daisy, I can see your hand finally.
Awesome. Jen, you're in this draft that we're looking at, this was a strike all from the Senate, right? And so you're going to highlight any changes from the Senate that the Senate made to what we did. Is that right?
No, I think we've looked at the changes in the underlying bill. This is just the proposed amendment that would replace white bagging, as I understand it. So
Okay.
we've not incorporated these into an actual amendment because we've just been looking at this as kind of standalone language, but.
Okay, thank you. Just orienting myself.
Yes.
What we'd be voting on is we would be amending.
Right, we should look at
striking out section whatever and inserting there in lieu of.
Or we should look at what they sent over so you can make sure that you're taking out what you want and keeping what you want.
Yep.
Okay, got it.
Okay, we have the hospital updating the ASP for each drug annually on January 1st and July 1st based on the CMS calculations for the most recent calendar quarter. Used to have the no balance billing and no increasing other costs in an effort to offset reduced revenue. And then here's where we come to the first change we're looking at today. So if a hospital demonstrates to the Green Mountain Care Board in its budget submissions that the price cap from subsection A is having a negative impact on access to care, the quality of care, or the sustainability of rural healthcare services, or a combination of these, the hospital may propose to increase, and then this language would change from increase its commercial reimbursement rates for preventive care or essential community services or both, to the hospital may propose to increase the reimbursement rates for one or more of its service lines, such as primary care, and the board shall consider both the demonstrated impact and the proposed increase to reimbursement rates. Based on the chair's question earlier, I thought it did seem to be sort of a fairly closed universe about what the hospital could propose to increase, recognizing the board, of course, has the authority to approve whatever budget they want, but it seemed confusing to call out only a few types of services, and there did not seem to be general agreement or understanding on what essential community services were. So this highlights, I think, this committee's continuing interest in primary care and reimbursement rates for primary care, but gives it as a such as.
And I will say personally, I have a problem when people use the term preventive care because people conflate preventive care with primary care, and one is a subset of the other. They are not the same thing. But anyways, that's my read. Yes.
The Venn diagram we discussed with Mary Kate during our S126 conversation. So then we still have provisions remain in effect unless and until the Green Mountain Care Board establishes a different reference-based price under its rate-setting authority that applies to prescription drugs administered in an outpatient or office setting. And then the change we made yesterday, this section shall not apply to an independent hospital that is designated as a critical access hospital and that is not affiliated with another hospital or hospital network based in or outside of Vermont. And then similar language for the short term, so effective July 1st. But this is setting that limit at 130%. So saying a hospital shall not submit a claim to a health insurer for reimbursement of a prescription drug administered in an outpatient or office setting between July 1st and December 31st of 2025 in an amount that exceeds 130% ASP as calculated by CMS for the most recent calendar quarter for any drug for which the hospital charged any health insurer more than 120% of ASP in effect as of April 1st, 2025. And then again, if it was 120% or less as of April 1st, 2025, then they cannot charge the insurer a greater percentage of ASP than the percentage of ASP that the hospital charged as of April 1st, 2025. And then the change here is to add in, again, that carve-out language, same carve-out language for critical access hospitals. Will not apply to an independent hospital designated as a critical access hospital and that is not affiliated with another hospital or hospital network based in or outside of Vermont. It was flagged for me that language was not included in here, and I did not think that was your intent. That was just my quick drafting, not thinking about it. And that's it for these changes.
Any questions for Jen on this language? Any comments? Thank you. Yes, thank you, Jen. Heather.
Jen, can you give us a specific example of what kind, by name, of what kind of a hospital B would be?
It's the same as in the first section. I'm not going to remember who the critical access hospitals are.
Springfield, for example, Springfield.
Different.
Manascutney is affiliated with the hospital network.
Yes.
So it is not included.
Oh, okay. Copley, Gifford.
North Country,
Okay.
Southeastern.
I just want to make sure.
8, 9, 8.
Eight,
Yeah, want to make sure.
eight, but not all are unaffiliated with.
Yeah.
So it's a smaller group than, it's a subset of critical access hospital
Thank you.
6.
because Manascutney and Porter. would not be included.
And then Central Vermont's PPS.
I should. Yes, Devin.
Green Vermont Association of Hospitals and Health Systems. I will just mention that both Sharon Foster and the healthcare advocate talked about Brattleboro Memorial Hospital. Not having very many resources. And eventually not being included in this bill.
And there is a carve out where if a hospital demonstrates to the Green Mountain Care Board price cap will have a negative impact. The board can propose increasing other service lines to make up for that.
Correct, but my understanding is this bill goes into effect July 1st. When do the prices actually hit the hospitals?
July 1st.
July 1st. So will be 3 months of the hospital not knowing whether or not that will work because the orders don't come out until October.
I hear you. Okay, Jen, can we look at the bill as came over from the Senate?
That is just what I was expecting. Yes.
Request
Yes.
to, there's a way we can have, so I was looking at an older slide of what the what were considered critical access hospitals, the amount of Scott Payne was listed on it. Can we have,
It is still a critical access hospital. It's just,
but it's associated, so if we could. have a
right, so
list of-
this carve out,
If we could have a list of the hospitals that this
Yeah,
bill
if
doesn't
maybe
affect.
Voz could get us that list, please.
And that,
Do you want that before you vote on this?
No,
Okay.
just to help with
Oh, okay.
constituent communication.
Yeah.
Which hospitals have what issue to deal with.
Could be affected.
okay, here is the Senate proposal of amendment. So this is what the Senate sent back over to you. And this is, again, just reorienting us to the topic and accurating to the 340B prescription drug pricing program. So section 1, they did not make any changes to what you sent over to them on the limitations on manufacturers restricting use of contract pharmacies in the 340B program. Section 2 is the reporting, hospital reporting on their participation in 340B. And they did make some changes that were the result of compromise between the Healthcare Advocate and Hospital Association. So we had looked at some different financial information coming in. Many of the provisions were the same or very similar, but there's also the addition of, in addition to the public information, some confidential or proprietary information being provided to the board about vendors who help a hospital manage, administer, facilitate part of their 340B program. You still have the sunset on the reporting on January 1st of 2031. And then sections 4, 5, and 6, all related to white bagging. So section 4 took out the ban, repealed the ban on white bagging. Section 5 put it back in. And section 6 directed the Green Mountain Care Board in consultation with DFR to report on the impact of the repeal of ban on white bagging on hospital budgets, health insurance premiums, and insurer solvency. So if you're looking to do the language we have been talking about this morning, instead of the white bagging, my expectation is we would take out sections 4, 5, and 6, put in what I've called sections A and B as sections 4 and 5, and then modify the effective dates. Take out section 5, which was putting back the ban on white bagging, adding in some new provisions specific to the effective dates of sections A and B with their respective July 1st for section B and January 1st for section A.
So the white bagging would be eliminated.
That is my understanding of what the
Okay.
chair had been proposing.
Okay, thanks.
That we would be inserting what we've been working on in lieu of what the Senate did with the white bagging.
So the upshot would be that the ban on white bagging would remain in place.
Before we straw poll this, do we have to have that done?
You may want, so I think you're gonna need to decide who is proposing this amendment, because the bill has not been referred to the committee.
Okay,
So whether that means you want all members of the committee on it. But I believe the bill is just on the calendar.
okay. It wouldn't be that the Committee on Healthcare proposes to amend.
If you propose to amend a bill, you don't have possession.
Oh, okay, that's right. That's right, it's on the calendar. Lori.
Happy to put my name as a sponsor.
Yeah, me too.
Yeah, and that may go along with your conversation around your straw poll, or your actual poll, who wants their name.
Okay, well, in that case, I move that, or I am proposing that we amend with the amendment as prepared by Jen and removing white bagging. And I think we should have some committee discussion around it. And then if everybody or no one wants to put their name on it, then I'll put my name on it. And then we'll straw poll it. That sounds reasonable? Okay, is there any committee discussion? Daisy, I saw your hand up and then down.
Oh, because I was just gonna say, yes, I support that and I'd be happy
Okay.
to support the
Okay.
amendment.
Thank you. All right, did you, you were just
No, I'm
looking at
reading
me.
the
Oh,
momentum,
okay.
raise my hand saying, yes, I support the amendment.
Yeah, and again, I keep going back to it because I think I've gotten caught up in the last couple days personally, and I just wanted to remind us that we did this bill. And I don't know why you all voted for this bill, but I know that I voted for this bill originally because it would help our FQHCs. And that was where I was on it. And one of the consequences of protecting our FQHCs was that it also would protect our hospitals who participate in 340B. And I keep going back to their testimony about how it would actually increase their revenue. We're still doing that. And now we're just taking a piece and carving out some specifics to help the system as a whole. And I also go back to all of our committee discussion around every single bill we've done, and we keep sitting here saying, what are we doing now? What are we doing now? What are we doing now? And this is our one and only opportunity to do something tangible right now. So.
And I would, I agree with this. And I, would want my name on it.
So can I have a show of hands of who would like their name on it? Okay, so everybody except for, unfortunately, Brian is dealing with something.
Yeah.
Yep, everyone on the committee.
Okay. You put your hand up.
All right.
Did Representative Rebecca Lawson?
Yes. So I guess I'll make a motion that we propose to amend H266 Senate proposal of amendment by inserting our amendment and striking out the white bagging sections. That's like the worst motion ever.
You just say what she said?
Yes, exactly.
Yeah, we will.
And all those in favor, with a show of hands. So 10-0-1 in favor.
Celebration.
Thank you. Thank you, everybody. Great.
So from a mechanic standpoint, I'm looking at having you concur Senate proposal of amendment with further proposal of amendment by striking out sections 4 through 7 and putting in your new sections 4 through 6.
That sounded so much better than what I bothered.
I can't.
Thank you.
That means when it's on the floor, people, I guess if you're doing it today, it'll be just posted anyway, I don't know if you're doing it today.
And I had said, because Daisy's not able to be with us today, I will propose that we delay action on this. Okay.